Iron deficiency anemia is a microcytic hypochromic. It's the most common type of anemia, most common type. Presentation, they'll have fatigue and pallor, exertional dyspnea, sometimes glossitis, angular cheilitis, and pica. So glossitis is the smooth tongue. Angular cheilitis is cracks in the corner of the mouth, the lips. And then pica is wanting to eat non-food items like clay, ice, things that are non-nutritive. If they have very severe, they'll have koilonychia. That's what this picture is here. It's the spoon-shaped nail. You can also have heart problems with long-term iron deficiency anemia because you now no longer have cells that are very capable of moving oxygen around your body. The heart is going to have to work harder to try to move around the cells that it does have. So you'll end up with tachycardia, murmurs, and heart failure. An iron panel is always going to be done if a patient presents with fatigue. It's one of your fatigue panels. Fatigue, you can look at the patient's thyroid. You're going to look at various different things, sleep apnea. Are you sleeping well? Various things like that. But you also always want to check an IDA because it's so common. The early stages, let's talk about what the labs look like throughout this. Early stages of iron deficiency is the slow depletion of the iron stores. And which one was the stored iron? Ferritin, because it's the tin of iron. This means there's still enough iron to make red blood cells, but the stores, the ferritin, is being used up without adequate replacement. The serum level may be normal in this stage, but the ferritin level will be low. All the stored iron ferritin has used, so we've used up all of our ferritin, so the body is going to try to start compensating. So every time our body does something wrong, there's always like a compensatory mechanism behind there that's going to try to fix it, but not really work. So it makes our labs look weird. So we're going to have our transferrin increase, our transfer, that's our car. The body says, I'll make more cars. If I make more cars, I can go get more iron and bring it here. But that doesn't work because we used up all of our ferritin, our stored iron. Now we've got a high level of cars. There's transferrin looking around everywhere. That means we've got a high TIBC because there's lots of open cars for us to fill up. And the serum level of iron will now start to decrease as well. The transferrin and TIBC are going to increase. Now we're going to have these really small pale cells. So we're going to have that microcytic hypochromic red blood cells on a smear. And this will result in iron deficiency anemia. If the ferritin alone is low, they shouldn't be symptomatic, but you do need to replace the stores. As it goes on, again, that transferrin and TIBC will start to elevate, the serum iron will go down, and eventually your H&H will be affected, and the smear will be affected, the RDW will be affected. What could cause this? Think blood loss, think menstruation, GI bleed, trauma, poor diet, pregnancy, which is more about a fluid volume. You're going to have a low MCV, low MCHC, low volume, low color, low ferritin, and low iron. You're going to have a high TIBC, high transferrin, and an increased RDW because you're going to have a wide range of size of cells. Treatment, you're going to treat and correct it if possible, if you can find the source of the problem. So if maybe they're having heavy periods, they need to decrease their inflammatory foods because that will help decrease heavy bleeding associated with hormones. And then you want to supplement 325 milligrams per day for 3 to 6 months to replace the stores. After 2 weeks, you want to check the reticulites and CBC to see if they're increasing. That'll let you know right away within those first 2 weeks if we're headed in the right direction. And 3 to 6 months, continue it out, and then you can repeat the panel to see how we're doing. How do we take iron? The best form of iron is ferrous sulfate, which is available over the counter and is incredibly affordable. We recommend that patients take it with a vitamin C tablet or with orange juice. There are some rules about the timing of taking iron that your nurse will need to educate on, or you need to make sure it's on the handout when you need to discharge them. Take 4 hours after taking an antacid. Take 2 hours before or after antibiotics, and do not take with dairy. Because what will happen with the dairy, I believe it's the calcium will bind to the iron and then make it basically ineffective. It causes black stools. That's a normal side effect. We need to educate the patients on that so they're expecting it. It can cause constipation or GI upset. Some people will end up having to take it with food. That decreases the absorption, but at least they're getting some, not none. And then with the constipation, you may have to have them do a stool softener. It will also cause your FOBT to be falsely positive. So it will give you a false positive that there's blood in the stool if the patient is taking iron.